Um, in my previous lecture, I talked briefly about the bones of the wrist and hand, just to give you an overview of what the different bones and joints are in the wrist and hand, just because we were talking about the antebrachial muscles, the forearm muscles, which are muscles that primarily move the hand and move the fingers. But I want to go back and cover the bones of the wrist and hand in a little bit more detail today. So in the wrist, there are a group of 8 bones known as carpals. And you see the list of their names over here on the right. The carpal bones are arranged into 2 rows. There's a proximal row of 4 carpals, which would be closer to the forearm. And then there's a distal row of 4 carpals that are closer to the fingers, and these articulate with the metacarpals of the hand. I've listed them in a certain order here, and I think trying to remember them in this particular order just makes it a little bit easier. First, we have the proximal row bones, and then the distal row bones. And in each of these rows, they begin on the lateral side, so that would be the thumb side, and then work our way from lateral to medial across each row. So here in the proximal row, starting on the most lateral side, and if you look down towards the bottom left, you'll see that that's metacarpal number 1, which is the metacarpal associated with the thumb. So starting on the lateral side, the first bone is the scaphoid, which has a sort of a rough hourglass or figure 8 shape to it. The lunate, which if you could see it from the side, you'd see that it has a very distinctive moon shape to it. In fact, I'll draw it over here. If you could see the lunate from the side, you'd see it has this very definite moon shape to it. You can't really see that here. That moon-shaped surface is down here, articulating with one of the bones in the distal row. Then continuing, moving medially, the next bone is called the triquetrum, and then finally a bone called the pisiform. Pisiform is just a tiny little round bone. I mean, it's pretty much circular or maybe slightly oval. It gets its name, pisiform, means shaped like a pea. Somebody thought it was shaped like a pea or like a little chickpea. So those are the 4 bones in the proximal row going from lateral to medial. Then in the distal row is the trapezium, and next to that is the trapezoid. Now those 2 are obviously going to be very easy to confuse because the names are so similar, trapezium and trapezoid. One way that you might be able to remember this is trapezium rhymes with thumb, meaning that it's the most lateral of the carpals in the distal row, and it's also the one that articulates with the metacarpal of the thumb out here. The trapezium has a distinctive sort of saddle shape to it. So if you look at it from the side, you'll see that there's this kind of saddle-shaped surface on one edge. Trapezoid is pretty nondescript. It's kind of hard to describe. Just roughly kind of a little wedge shaped, more or less. Capitate is next. I'm going to scribble over here on the other side of the page. The capitate has a kind of a rounded head and then a somewhat wider base. And I've always thought it looked like a pawn on a chess set, you know, with that rounded head and then the wide base like you see on the pawns on a chess set. And then finally, the last bone, the most medial bone in the distal row is called the hamate. And if you look here, you see there's this thing that's projecting towards us. If you view that from the side, that's a big prominent hook that sticks out from the anterior surface of the hamate, makes that bone very distinctive. You've probably noticed that I have a box filled with isolated carpal bones in the lab, and you will be responsible for identifying some of them. I'll tell you right away that I'm not going to expect you to identify triquetrum or trapezoid because they're pretty nondescript. But the others you should be able to recognize individually. The other
I've
thing,
got a question.
yeah, go ahead.
Does the pisiform sit right on top of the triquetrum?
Yeah, it sits anterior to the triquetrum.
Okay.
Yeah, and another little bit of trivia about the pisiform. The pisiform is an example of what we call a sesamoid bone, and I'll draw that for you here, or I'll write that word out. We'll come back to this word a few other times in the course. A sesamoid bone is a bone that grows within the tendon of a muscle. The pisiform grows within the tendon of the flexor carpi ulnaris muscle. So you've got flexor carpi ulnaris muscle coming down from the forearm, and the pisiform is actually embedded in the tendon of that muscle as it crosses the wrist. So something else to notice here in the illustration is there are a couple of other landmarks listed here on the radius and ulna. Both of these bones have a projection at their distal end called a styloid process. On the ulna, it's more of a pointed, almost sort of a tooth-like process. On the radius, it's much more of a broad, blunt process, but they're both these little processes that extend, distally from the tip of the bone. Something else to notice is that it's only the scaphoid and the lunate in the proximal row of carpal bones that articulate with the radius, and nothing articulates with the ulna. The pisiform and triquetrum bones never come into direct contact with the ulna. As a matter of fact, this whole space is filled in with a triangular shaped cartilage disc that separates the ulna from making contact with any of the carpal bones. So there's a joint in the wrist called the radiocarpal joint. It's the primary joint that we think of when we think of the wrist. That's simply formed between the scaphoid, the lunate, and the distal end of the radius. By the way, you might also notice that there's a little mnemonic included with the list of bone names, a little mnemonic just to help you remember the names of the bones. Just recognize the order that it's the first four bones, the proximal row first going from lateral to medial, and then the distal row going from medial to lateral, or excuse me, from lateral to medial. Same thing viewed on the posterior or dorsal surface of the wrist. Once again, you see scaphoid and lunate in the proximal row articulating with the radius, then triquetrum and pisiform, and then the distal row, trapezium, trapezoid, capitate, and hamate. The other feature to notice on here is something called the dorsal tubercle. This is an extra little bony process on the dorsal surface of the radius. This acts as a pulley to redirect one of the extensor tendons of the thumb. You might remember from last time, I was talking about some of the deeper muscles that lie in the posterior aspect of the forearm. And you'll see these muscles today because we're doing the posterior forearm and posterior hand today. But there's a muscle called the extensor pollicis longus, and that muscle comes down from the radius and passes this dorsal tubercle. The tubercle then acts like a pulley, allowing that tendon to change directions to continue all the way out to the distal phalanx of the thumb. The other bones in the rest of the hand, again, we've already talked about these a little bit, but just a little bit more detail here. There are 5 metacarpals numbered 1 through 5, usually using Roman numerals. Metacarpal 1 is the one that's associated with the thumb, all the way across to number 5, which is associated with the pinky. Now remember, these are not actually the fingers themselves. The metacarpals are what make up the flat part of the hand. Each metacarpal has a base at its proximal end that articulates with the carpal bones in the wrist, and then a rounded head at the distal end that articulates with the phalanges. The phalanges are the bones that actually make up the fingers themselves. In digit 1, the thumb, there's only a proximal phalanx and a distal phalanx. In the other 4 digits, digits 2 through 5, there are 3 phalanges: proximal phalanx, middle phalanx, and distal phalanx. We also talked about the joints a little bit already. I just want to review them quickly. The radiocarpal joint is the joint between the two of the carpal bones in the proximal row, the scaphoid and lunate specifically, and the distal end of the radius. This joint is capable of flexion and extension, so the hand flexes and extends at the wrist joint, and also abduction and adduction. So in anatomic position, when you abduct the hand is rotating away from the body, and in adduction, the hand rotates back towards the body. There's a midcarpal joint, which is just a collection of joints between the bones in the proximal row and the bones in the distal row. And there's really not a whole lot of motion that occurs at these joints. The carpometacarpal joints is a series of joints between the distal row of carpal bones and the metacarpals of the hand. The joints for digits 2 through 5 don't move very much. There's only a tiny amount of flexion and extension. And in class, last time I asked you to grasp your hand and reach into the middle of your hand and grab one of your metacarpals and see if you could wiggle that metacarpal forward and backward. And they really don't move very much at all. Maybe the one at your pinky might move forward or backward, maybe a half an inch or so. But there's really very little mobility at most of those carpometacarpal joints. The only one where there's a lot of motion is the first carpometacarpal joint. So that's the joint formed between the trapezium and the first metacarpal, the metacarpal of the thumb. That joint does allow quite a bit of motion. The thumb can flex and extend at that joint. It can abduct and adduct at that joint. And also there's a small amount of rotational movement where the first metacarpal can twist or rotate a little bit, which normally happens during opposition of the thumb. There's a set of metacarpophalangeal joints. These are between the heads of each metacarpal and the proximal phalanx of each digit. These can flex, extend, as well as abduct and adduct. With the fingers, you might remember that abduction involves rotating the fingers away from an imaginary midline, and that imaginary midline is drawn right down the middle of the middle finger. So, when the pinky moves away from the middle finger, when the ring finger moves away from the middle finger, when the index finger moves this way away from the middle finger, that would all be abduction. Interestingly, the middle finger, regardless of which way it goes, it's always abducting, because if it moves towards the thumb, it's moving away from that imaginary midline. If it moves towards the pinky, it's also moving away from that imaginary midline. So the thumb is always abducting. Then the opposite motion of rotating the fingers back towards that imaginary midline would be adduction of the fingers. And those motions of abduction and adduction are occurring here at these metacarpophalangeal joints, as well as flexion extension at those joints. Then there's a series of interphalangeal joints. Out in the thumb, there are only two phalanges. There's a proximal phalanx and a distal phalanx. So there's only one interphalangeal joint. But in the other digits 2 through 5, you have 3 bones. So you have a proximal, middle, and distal phalanx. And so there's a proximal interphalangeal joint between the proximal and middle phalanges. This is referred to or abbreviated DIP or PIP joint, excuse me. And then there's a distal interphalangeal joint between the middle phalanx and distal phalanx. And this is abbreviated DIP joint. So here's a slide that just summarizes all of the motions of these joints that I just described. I'm not going to dwell on this, but you should come back and look at it just to refresh your memory about the different motions that occur at these joints. All right, so we're going to continue moving from the wrist down into the hand. And what you're looking at here is an overview of the carpal tunnel. This is a horizontal or axial cross-section taken through the wrist, and you can see the bones there. This happens to be the distal row. So this one would be, oops, sorry, I'm gonna turn my drawing tool back on. This would be the trapezium, the most lateral bone in the distal row that's associated with the thumb. This is the trapezoid, the capitate, and the hamate. You can actually see the hook on the anterior surface of the hamate right there. Notice that the carpal bones are arranged in kind of a U-shaped structure, forming a sort of a tunnel right here through the middle of that U. This is true here in the distal row of carpals. It's also true in the proximal row of carpals, which you can't see in this picture. But both rows of carpals are arranged to form this U-shaped trough or channel. Then there's a ligament that connects the carpals on the medial side over to the carpals over on the lateral side. And you can see that labeled here, called flexor retinaculum, and it's shown in green. This flexor retinaculum forms a sort of a roof over the top of that tunnel. So the arrangement of bones forming this U-shaped trough or channel, and then with the addition of that flexor retinaculum forming a roof over that space, this all combines to create what we call the carpal tunnel. So the carpal tunnel is simply this space between the carpal bones and the flexor retinaculum. Now, the carpal tunnel is very important because there are several important structures passing through there. You have several tendons coming down from the forearm, traveling out to the digits. These would be the flexor tendons, the long flexor tendons of the digits. So you have flexor digitorum superficialis, abbreviated FDS in this picture. You might be able to tell if you look at it closely that the tendons are stacked up. So there's two tendons more superficially and then two tendons that lie just deep to it. But those are all FDS tendons. They're just stacked two and two. And then deep to those are the flexor digitorum profundus tendons, or FDP. The four FDP tendons are lying side by side. They're not stacked on top of one another. And then finally, you have something I labeled FPL here. That would be the flexor pollicis longus, which is heading out eventually out to the thumb, to flex the thumb. And then some other structures that are found here in the carpal tunnel. The flexor tendons are all surrounded by these synovial sheaths. It's the same material that you find surrounding a synovial joint. It secretes a little bit of synovial fluid, which acts as a lubricant. And here in the carpal tunnel, the purpose of this lubricant is to allow these tendons to slide easily back and forth within the carpal tunnel. So as you flex and extend the wrist, and also as you flex and extend the digits, these tendons are pulling back and forth and sliding back and forth within the carpal tunnel. So these synovial sheaths and the little layer of fluid that they secrete serves as a lubricant to just allow for that easy movement. And finally, notice the last structure within the carpal tunnel is the median nerve. This is the only nerve that passes through the carpal tunnel. The ulnar nerve is over here. It's actually outside of the tunnel. The ulnar artery is outside the tunnel. Here's the radial artery going around the back of the wrist, which is also outside the tunnel. But the median nerve is actually contained within the carpal tunnel, deep to the flexor retinaculum. And that's going to become important in a minute because we'll talk about carpal tunnel syndrome. And it's really the median nerve that's really important. Here's just a different view of the carpal tunnel. This is an anterior view, and you can see the FDS and FDP tendons coming down from the forearm and passing deep to the flexor retinaculum. You can also see FPL or flexor pollicis longus tendon, also passing deep to the flexor retinaculum. The nerve that you can see running along with those tendons is the median nerve. And then the median nerve kind of peeks out from the carpal tunnel down here after it's, so down here you see median nerve emerging from the tunnel. So here it is entering the tunnel up above and then emerging from the tunnel down below. You can also see in blue the synovial sheaths surrounding those tendons to create that lubrication as these tendons, slide back and forth through the tunnel. So people will sometimes ask me, oh, as an artist, do you have carpal tunnel? And I say, why, yes, I have 2 of them, because everybody has 2 carpal tunnels. A lot of people think that the phrase carpal tunnel refers to the actual syndrome, where you have pain in your hands as a result of overuse. So everybody has 2 carpal tunnels. It's just don't confuse that with the actual condition or disease. So the proper name for the actual condition, the medical condition, would be carpal tunnel syndrome. So it's a syndrome or an illness affecting the carpal tunnel. What happens in carpal tunnel syndrome is that all of those flexor tendons that are passing through the carpal tunnel, they become enlarged, and they can become inflamed, and this results in what's called swelling or hypertrophy of those tendons. So specifically, we're talking about FDS, FDP, and FPL tendons that are passing through the tunnel. These actual tendons can be enlarged, or maybe the tendons themselves are not enlarged, but that synovial sheath surrounding the tendon may become inflamed, and that may become enlarged, or it may secrete excess fluid so that there's a buildup of fluid within the synovial sheaths inside the carpal tunnel. But either way, you end up with swelling or hypertrophy or enlargement of the structures within the carpal tunnel. There are several things that can cause this hypertrophy or swelling or inflammation of the tendons or their sheaths. Sometimes it could be the result of a direct injury to the wrist. So you could just have like a crushing injury or an impact to the anterior surface of the wrist that could cause the tendons to swell and inflame. Could also be the result of an infection. There could be a small penetrating wound that introduces bacteria into the carpal tunnel, which then results in a bacterial infection, which can cause inflammation and swelling of those tissues. But the thing that most of us think of, the cause that most of us are familiar with as resulting in carpal tunnel syndrome, are any kind of repetitive grasping or flexing movements. In particular, anything that involves repetitive flexion of the fingers and thumb. Over time, that can result in those tendons enlarging and hypertrophying. So think about a secretary who's sitting at a computer keyboard just typing letters and stuff all day long. That constant flexion, extension motion of the fingers is putting constant stress on all these flexor tendons, the flexors of the digits, resulting in gradual hypertrophy of the tendons. Artists, people in our profession are very susceptible to carpal tunnel. Either, back when we worked in traditional media, from grasping pencils and paintbrushes, nowadays from grabbing and clicking a mouse or holding a Wacom stylus, you can end up with carpal tunnel syndrome just from that constant grasping and flexing of the fingers. People in construction who are grabbing hammers and wrenches and so forth, or screwdrivers and things all day, they can develop this problem. So any of these kinds of professions that involve these repetitive grasping motions can end up with carpal tunnel syndrome. So what's happening specifically in the syndrome is that the tendons enlarge, or the synovial sheaths enlarge or swell or fill up with fluid. And this ends up compressing the median nerve. You know, as the tendons and synovial sheaths get bigger, they really don't have a lot of room to expand because that carpal tunnel is so restricted. It's a very small area, it's very tight. So as the tendons expand, they're going to compress everything around them. And the median nerve is the one important structure that's passing through there that can be squished. So the median nerve becomes compressed. And this results in symptoms coming entirely from the median nerve. So there are no symptoms from the hypertrophy of the tendons themselves. You don't feel that. All you feel in carpal tunnel syndrome is just the compression of the nerve. Well, if you think back to our previous lecture, I gave you a quick overview at the very end of the nerve distribution of the median nerve. The median nerve is responsible for sensory innervation from the palm of the hand, at least on the lateral side, basically the palm area overlying the thenar muscles of the thumb. And it's also a sensory nerve to the skin of the thumb, the index finger, and the middle finger, digits 1, 2, and 3. Now, normally in cases of carpal tunnel syndrome, you do not have pain or numbness in the palm because there's actually a separate branch of the median nerve that innervates the palm, and that branch does not actually go through the carpal tunnel. I'm going to try to back up here. If you look on this picture, you'll see that the median nerve is giving off a tiny little branch right here. That little branch is the sensory nerve to the skin over the palm area, in this area. But notice that that branch is coming off of the median nerve before the nerve goes through the carpal tunnel. So that means that this little branch supplying the area of skin over the palm is not going to be affected by carpal tunnel syndrome. The only parts of the nerve that are affected are these parts down here that are actually going through the tunnel. So these are the nerves that are sensory to the thumb, the index finger, the middle finger, and even potentially a little bit of the ring finger. So digits 1, 2, 3, and maybe a little bit of digit 4 can be affected in carpal tunnel syndrome. So people typically feel the pain of carpal tunnel syndrome in those first 3 to 4 digits, but not usually in the palm itself. The median nerve is also responsible for innervating the thenar muscles. Some of you in lab yesterday saw something called the recurrent branch of the median nerve. So after the median nerve goes through the carpal tunnel, it gives off a tiny little branch to the thumb that supplies the 3 thenar muscles. This is flexor pollicis brevis, abductor pollicis brevis, and opponens pollicis. So with compression of the median nerve, you can lose innervation to those 3 muscles, which means you have limited motion in the thumb. Now, you still have other muscles that move the thumb. Like there's an abductor longus coming from the back of the forearm. That's innervated by a completely different nerve, so that's not affected. You have things like flexor pollicis longus, which is coming from the forearm. It's innervated by the median nerve, but way up in the forearm, long before the nerve goes through the carpal tunnel. So the flexor pollicis longus is usually fine. So you can make large movements of the thumb because some of the muscles are still okay. It's only these small muscles in the thenar eminence at the base of the thumb that are affected. So what you tend to lose is very fine motor control of the thumb. And as those thenar muscles lose innervation, they atrophy. It's like any other muscle. If you stop using it, it wastes away. And so you actually end up getting wasting or shrinkage of the thenar muscles at the base of the thumb. And I've seen people with very advanced carpal tunnel syndrome that they've had it for a very long time, and they have a noticeable dent or divot in that fleshy pad at the base of the thumb because all those muscles have actually wasted away. All right, let's keep moving down into the hand. So we've crossed the wrist through the carpal tunnel, and this is another horizontal or axial cross-section, but this time taken through the hand a little bit more distally, so a little bit farther down in the hand. And what you can see here are the tendons of the flexor muscles, which have now continued through the carpal tunnel into the hand. So you can see in this area, the FDS and FDP tendons stacked on top of one another. Now, Netter made an interesting mistake when he painted this. He only shows 3 sets of tendons, and yet there should be tendons going to all 4 digits, digits 2 through 5 in here. So there should be a 4th set of FDS and FDP tendons here in this compartment. But these flexor tendons, the superficialis and profundus tendons, they make up something called the central compartment. And if you look at these little pink ovals here in this central compartment, there's actually a set of additional muscles called lumbricals that are found in that compartment. We'll come back and talk about those more in just a minute. The central compartment also separates 2 other compartments from one another, 2 other groups of muscles. There are the hypothenar muscles on the medial aspect of the hand. These are a group of 3 muscles involved in movements of the 5th digit or pinky finger. And then the thenar muscles over on the lateral side of the palm. This is a group of 3 muscles involved with fine movements of the thumb or 1st digit. Just deep to the 3 thenar muscles is a 4th muscle involved in movements of the thumb called the adductor pollicis. This is listed separately. It's not considered one of the thenar muscles because it actually lies in its own separate fascia compartment, separate from the thenar muscles and deep to the thenar muscles. And then finally, there's a whole group of muscular compartments that lie between the metacarpal bones in the hand. These are known as the interosseous compartments or the interosseous muscles. So they get their name from the fact that they lie in the spaces between the bones. Here's an anterior view of those same structures. Over here on the medial side of the hand, we have the hypothenar muscles. There's an abductor digiti minimi. By the way, all of the hypothenar muscles are going to have this name digiti minimi, just meaning the littlest digit. There is also an alternative name that you might see occasionally. You might see these listed as abductor digiti quinti or flexor digiti quinti. Quinti just means 5. It's the Latin word for 5 or 5th. So that would mean the abductor or the flexor of the 5th digit as opposed to the little digit. I used to have a friend down in Atlanta, a guy that I used to work with, and he said his favorite structure was the digiti minimi quinti. Well, I hated to break it to him, but that's not a real name. It's kind of redundant to say minimi quinti because they mean sort of the same thing. Digiti minimi means the little finger. Digiti quinti means the 5th finger. So it's one or the other. It's either digiti minimi or digiti quinti, but not both. The abductor digiti minimi is going to insert on the base of the proximal phalanx of the 5th digit right around here. When that contracts, it's going to rotate the 5th digit medially, but that's moving it away from the midline of the hand. So that would be abduction, hence the name abductor. Flexor digiti minimi is going to flex the proximal phalanx. So it's going to flex the 5th finger at the metacarpophalangeal joint. There's another muscle just deep to these. And let's see if I can jump ahead. There we go. There's an opponens digiti minimi also. So you can see that the abductor here has been cut and the flexor here has been cut. And that allows you to see this other muscle that lies deep to the other 2 called opponens digiti minimi. Now, we normally think of the thumb in the human hand as being opposable, but it turns out the other digits are also opposable in the sense that these other digits can cross the hand to meet the tip of the thumb. So as you bring your thumb across your palm, you can also bring your pinky finger across the palm to meet up with the tip of the thumb. So that would be opposition of the fifth digit. So this opponens muscle is actually rotating the fifth metacarpal here. It actually rotates the fifth metacarpal laterally a little bit to help bring the pinky finger over to meet with the tip of the thumb. All right. By the way, all of the hypothenar muscles, all of the abductor digiti minimi, flexor digiti minimi, and opponens digiti minimi are all innervated by branches of ulnar nerve, which kind of makes sense. Some people have already noticed that there's a little bit of a pattern to the hand, that things that are on the medial side tend to be innervated by ulnar nerve, whereas things on the lateral side tend to be innervated by median nerve. So speaking of which, let's move over to the thenar muscles at the base of the thumb. There's an abductor pollicis brevis. So pollicis, you may recall, means thumb in Latin. So this is an abductor. So it's going to lift the thumb up out of the flat plane of the hand. Remember, that's abduction of the thumb. The brevis means that it's the short abductor. There must also be a longus somewhere. There must be an abductor pollicis longus somewhere. Does anybody remember where in the body the abductor pollicis longus is located?
It's in the forearm, right?
It's in the forearm. Yep.
The anterior side.
Anterior or posterior?
Anterior.
Yeah. You had a 50-50 chance of getting it right. The abductor pollicis longus is actually one of the posterior forearm muscles. You'll see that today in today's dissection. Flexor pollicis, then there's a flexor pollicis brevis. So the short flexor of the thumb, you can see that right here. Once again, if there's a brevis, there must be a longus. And I don't remember who shouted out that previous answer. I don't know if it was Zaid or Max or whoever. But where is the flexor pollicis longus?
That's on the anterior side.
That's in the anterior side, right? That's one of the deep muscles in the anterior compartment of the forearm. All right, let's see. So jumping ahead. Now, in addition to the abductor pollicis brevis and flexor pollicis brevis, we also have an opponens pollicis. If you cut, here's the abductor cut, and here's the flexor that's been kind of reflected out of the way a little bit. Now you can see this opponens pollicis. It's got a slightly different fiber direction to it. This is inserting on the first metacarpal, and it's also similar to the opponens digiti minimi. If this is the metacarpal of the thumb, it's going to rotate it slightly. It's going to kind of twist it slightly as you oppose the thumb, as you bring the thumb across the palm. All of these thenar muscles are innervated by this recurrent branch of the median nerve, which you can see here clearly on the slide. Here's the median nerve coming down through the carpal tunnel, and as soon as it comes through the carpal tunnel, it gives off this little recurrent branch right here that innervates those three thenar muscles. Deep to the three thenar muscles is a muscle called adductor pollicis. Something important to notice about the name of this muscle: there's no longus, brevis, or anything like that. It's just adductor pollicis. There is only one adductor muscle of the thumb. There are two abductors with a B. there are two flexors of the thumb, there are two extensors of the thumb, longus and brevis in all those cases, but only one of these, only one adductor. And this is going to pull the thumb down so that it lies next to the other fingers in the flat plane of the hand. This muscle is innervated by a specific branch of the ulnar nerve, known as the deep branch of the ulnar nerve. Here's the ulnar nerve coming down through the forearm, crossing the wrist, and then right at this point, the ulnar nerve is going to split, and it's going to give off a superficial branch, but then it's also going to give this deep branch, which goes deep down in the palm and goes all the way across to the lateral side of the palm to innervate this adductor pollicis muscle. So this is one exception to that general rule about the way that the forearm and hand are divided up. You remember earlier I was saying about how, you know, the hand and forearm are roughly divided so that things on the medial side are ulnar and things on the lateral side are innervated by median. But in this case, the deep branch of the ulnar nerve goes all the way across to the lateral side to innervate this muscle over on the lateral side. So there's kind of an exception to that general rule. All right. A few slides ago, I was showing you a cross-section through the hand, and I showed you how the tendons of the FDS and FDP continue down into the hand, and they form something called the central compartment, which lies between the thenar and hypothenar muscles. So you've got the hypothenar muscles over here on the medial side, you've got the thenar muscles over here on the lateral side. Then there's this central compartment, which is basically just a continuation of the tendons after they come down through the carpal tunnel, and they make up this large central compartment in the middle of the hand. By the way, notice these cut ends, these cut tendons down here. These are the FDS tendons, the flexor digitorum superficialis, and each superficialis tendon splits to create this Y shape, which are inserting on the middle phalanx of each finger, digits 2 through 5. And then you have the flexor digitorum profundus tendon that passes right through the middle of that split and continues farther out to have its insertion on the distal phalanx of digits 2 through 5. This was a relationship that we saw in lab yesterday. If you didn't see this relationship, that splitting of the FDS tendon with the FDP passing through, you should be sure to look at one of the dissected fingers and make sure you see that relationship. But the main thing I wanted to show you on this slide are these muscles that are numbered 1 through 4. These are the lumbrical muscles. Kind of an interesting group of muscles, because these are muscles that originate from the tendon of another muscle. The 4 lumbrical muscles are originating from the tendons of the flexor digitorum profundus muscle in here. So lumbrical number 1 is originating from the FDP tendon that's going out to the index finger. Lumbrical number 2 is originating from the tendon going out to the middle finger. Lumbricals number 3 and 4 are a little different because they are bipennate muscles. So lumbrical number 3 is originating from the tendons of both the middle finger and ring finger. And same thing with lumbrical number 4, it's also bipennate, originating from the tendons going to the 4th and 5th digits, the ring finger and pinky finger. These lumbrical muscles, so they're originating from the tendons of the flexor digitorum profundus, but then if you follow them around, you can see that they insert on the posterior surface of the fingers Specifically, they're inserting into something known as the extensor expansion of digits 2, 3, 4, and 5. We'll see the extensor expansion on the next slide so you can have a better understanding of what it is. But essentially, it's just a sort of a hood that sits on the dorsal surface of each finger. It's like a hood of tendon on the back or dorsal surface of each finger. And it's derived partially from the extensor digitorum tendons in the back of on the back of the hand. We'll wait until the next slide and I'll show you why that's important for the function of these muscles. But before we move on to the next slide, just a couple of points. First of all, these 4 lumbricals are going to flex the metacarpophalangeal joints. So those are these joints right here. So they cross these metacarpophalangeal joints and they're going to assist in flexion of those joints. But then when the lumbrical tendons pass over to the dorsal side of each finger, now the tendons have crossed to the back of each finger and they attach to this thing called the extensor expansion, which is on the posterior surface of each finger. At this point, these lumbrical muscles are going to extend these 2 joints. So they're going to extend the pip joint here and extend the dip joint here. So it's kind of interesting that these muscles will flex one set of joints, the metacarpophalangeal joints, but simultaneously extend the pip and dip joints in the fingers. The other thing that's kind of interesting about the lumbricals is that they have this split innervation. Lumbricals number 1 and 2, which are more lateral, are innervated by median nerve. Lumbricals 3 and 4, which are more medial, are innervated by ulnar nerve. So this is a situation that really does follow that division that we talked about, where things that are more medial are innervated by ulnar nerve, things more lateral, innervated by median nerve. So here you see a lateral view of an individual finger. And there's a lot of interesting stuff that you can see in this picture. So first of all, let's look at the bottom of the picture. And let's take a look at the flexor digitorum superficialis tendon. So that's coming down from the forearm, through the carpal tunnel, through the central compartment of the hand, all the way out here along each finger. And this is the muscle that's going to split and then insert here on the middle phalanx of each digit. Just deep to that is the flexor digitorum profundus tendon. That's going to pass through the middle of that split. So it's going to pass through the middle of the FDS tendon and continue farther out to insert out here on the distal phalanx of each finger. So flexor digitorum superficialis is primarily going to flex the pip joint, and flexor digitorum profundus is primarily going to flex the dip joint. On the dorsal surface of each finger, or posterior surface of each finger, we have the extensor digitorum tendons. These are coming from the extensor digitorum muscle, which is one of the posterior forearm muscles. And the extensor digitorum tendons come down and they expand to form this thing called the extensor expansion. Like I say, it's sort of like a hood or a sheet draped over the dorsal surface of each finger. When the extensor digitorum muscle contracts, it's going to extend the metacarpophalangeal joint, it's going to extend the pip joint, and it's going to extend the dip joint. So it's extending all 3 of those joints in each finger simultaneously. Well, now let's look at the lumbricals. So the lumbrical is originating here on the anterior surface of the hand, specifically, coming off that FDP tendon. And the tendon of each lumbrical is then going to pass around to the dorsal surface of each finger. Well, I think you can tell from the orientation of the muscle that it's going to flex this metacarpal phalangeal joint. It's going to pull the proximal phalanx anteriorly to flex the metacarpal phalangeal joint. But then the tendon of each lumbrical muscle then blends in with this extensor expansion on the posterior or dorsal surface of each finger. So by pulling on that extensor expansion, it's going to extend the pip joint and extend the dip joint. So kind of an interesting function for these lumbricals. And here you see that, whoops, here you see that happening. So here's the lumbrical muscle pulling, and it's pulling the metacarpal phalangeal joint, which would be up here, pulling that into flexion by pulling the proximal phalanx anteriorly. But then by pulling on this extensor expansion, it's extending the pip joint and extending the dip joint. Okay, sorry. Keeps jumping ahead on me. All right, the last group of muscles in the hand, and as you probably noticed, there's a lot of muscles in the hand. There's 19 muscles just in the hand. You probably didn't see them all yesterday because these muscles that I'm going to talk about now are just a little bit too deep, but you should still be familiar with them. There's a group of muscles called interosseous muscles, or interossei. And these are muscles that lie in those muscular compartments between the metacarpal bones of the hand. So these are very, very deep in the hand. There are two distinct layers of interosseous muscles that lie in these spaces between the bones. There's a palmar group, palmar interossei, and then a dorsal group, or dorsal interossei. Now remember, they're all sandwiched in between the bones. So they're very, very deep in the hand. It's just that some of them are a little bit closer to the front, so we call those palmar, and others are a little bit closer to the back, so we call those dorsal. So there are three palmar interossei, or interosseous muscles, that you can see here on this picture. And they're simply numbered 1, 2, and 3. Number 1 is originating from the second metacarpal. Number 2 is originating from the fourth metacarpal. And number 3 is originating from the fifth metacarpal. So don't get confused between the numbers and the bone that they're originating from, because the number of the muscle doesn't necessarily coincide with the metacarpal that it's originating from. The palmar interossei are responsible for adduction of some of the digits. Not all of them, but these here specifically. Palmar interossei adduct digits 2, 4, and 5. So you can see that the first palmar interosseous is inserting on the proximal phalanx of digit 2 right here. So when it pulls on proximal phalanx, it's pulling it in such a way that it rotates medially towards the central axis of the hand. Lumbrical number 2 is inserting on the fourth proximal phalanx. So when that contracts, it's pulling this way. It's going to rotate the fourth digit towards the midline, and then out here the third palmar interosseous is going to pull on the proximal phalanx of the fifth digit and rotate the fifth digit towards the central axis of the hand. So the palmar interossei adduct digits 2, 4, and 5. I've included a little abbreviation, like a little acronym up here, PAD, which is how I remember what these muscles do. PAD is short for palmar's adduct. So palmar interossei adduct some of the digits, specifically digits 2, 4, and 5. All of the interossei are innervated by the deep branch of the ulnar nerve. This is true for both the palmar and dorsal interossei. They're all innervated by the deep ulnar nerve. Sorry, having a lot of trouble finding my cursor because it's disappeared. There we go. All right, these are the dorsal interossei. So we're actually looking at a posterior or dorsal surface of the hand just because it's a little easier to see these from the dorsal side, but you can see how they're still embedded in the spaces between the bones. There are 4 dorsal interossei, one here that lies between the first and second metacarpals, one here between second and third, another one here between third and fourth, another one here between the fourth and fifth metacarpals. Even though there's 4 of them, they're only responsible for movements of 3 of the digits. These are going to abduct digits 2, 3, and 4. So the first dorsal interosseous is inserting on the proximal phalanx of digit 2. When it pulls over here on the lateral side of that proximal phalanx, it's rotating it this way, rotating it away from the central axis of the hand. So that would be considered abduction of digit 2. There's also the fourth dorsal interosseous is inserting on the fourth proximal phalanx, and when that muscle contracts, it's going to rotate the fourth digit away from the midline of the hand, so that would be abduction of digit 4. And interestingly, there are actually 2 interossei, or excuse me, 2 dorsal interossei that both attach to the third digit, the proximal phalanx of the third digit. One of them is attaching on the lateral side here, which is going to rotate the third digit, in this direction, which is abducting it away from that central axis. Then the third dorsal interosseous is going to pull this way, which is going to rotate the third digit in this direction, which is also moving away from the central axis of the hand. So as I said earlier, the middle finger always abducts. So regardless of whether it goes this way or goes this way, it's moving away from the central axis of the hand. So that would be abduction with a B. So these muscles are abducting digits 2, 3, and 4. Now, what about digit 1, the thumb? Is there anything that abducts that? Well, there are actually 2 abductors of the thumb, but they have their own special names. There's abductor pollicis brevis and abductor pollicis longus. And then there's also an abductor of the 5th digit, which is one of the hypothenar muscles. This is a muscle that's called abductor digiti minimi, and that's going to abduct the 5th digit. But it's not an interosseous muscle because it's not actually in the spaces between the bones like these others are. All right. I also want to talk a little bit about arteries and nerves as they pass into the hand and the functions of these arteries and nerves. Let's talk about the arteries first. So there are 2 major arteries, as you know, up in the antebrachium. There's the ulnar artery over on the medial side, and then radial artery over on the radius or lateral side of the antebrachium. The ulnar artery is going to cross the wrist on the anterior side and enter into the hand. The ulnar artery does not actually go through the carpal tunnel. It does have its own separate little tunnel that it passes through, but it's not the same thing as the carpal tunnel. As soon as the ulnar artery crosses into the hand, it changes names. And it's now referred to as the superficial palmar arch. And I think most of you saw that in lab yesterday. And superficial palmar arch, if you have a complete one, it forms a kind of a J-shaped structure in the palm of the hand. Now, the superficial arch may receive a small contribution from the radial artery, but that's not always present. And even if it is present, it's frequently very small. So the superficial palmar arch is coming primarily from ulnar artery. The superficial palmar arch then gives off a whole series of digital arteries that are supplying blood to the individual fingers. And you might notice that you start out with what's called a common digital artery, where it's like one branch off the superficial palmar arch, but then that is then going to split into two smaller arteries that run down the adjacent surfaces of the fingers. So if you look down here, if I can draw this, so we have a small branch here and a small branch here, both coming off of one of these common arteries. So there's common digital arteries, and then once they split, they're known as proper digital arteries down here. I'm going to jump ahead to the next slide and continue talking about arteries for a second. And we'll come back to these. So we saw the ulnar artery, as I said, crossing the palm to become the superficial palmar arch, and then giving off these common digital arteries, which then split into proper digital arteries out in the fingers. The radial artery actually ends up turning posteriorly. So after, or right about the point where it crosses the wrist, it makes a posterior turn and actually ends up behind the thumb, or posterior to the thumb back here. But after it wraps around the thumb, it comes back into the palm to form something called the deep palmar arch. So it's another arch in the palm, but it lies much, much deeper in the hand. You have to do the deep dissection of the palm in order to see this deep palmar arch. So that means taking the FDS and FDP tendons out of the carpal tunnel and reflecting them down into the hand in order to expose, these structures in here that lie deep to to all of those flexor tendons in the palm. I noticed in lab yesterday that a few tables did perform the deep palm dissection, but I'm not sure that everybody did that. You were only supposed to do it on one hand on each cadaver, so you need to pick a side, pick one side of the cadaver to do the deep palm dissection on, but make sure that every table does it at some point. And of course, those of you in group A probably didn't get to see it at all. So, or I guess group B, technically, the first group that dissected didn't get to see it. So make sure that your table has performed one of these deep dissections, and make sure everybody gets to see it today before you leave. Because you'll be looking for the deep palmar arch, this little artery that lies in the deep palm, but also you'll be looking for this deep branch of the ulnar nerve down there as well. All right, let me jump back to the previous slide if I can get back to my, whoops. All right, so let's talk about the nerves now. The ulnar nerve is coming down through the forearm, and it also passes through its own little canal here at the wrist. It's not going through the carpal tunnel, so the ulnar nerve would not be compressed in carpal tunnel syndrome. Immediately after the ulnar nerve passes through this little tunnel and enters the hand, it splits into two branches. There's a superficial branch here, which is primarily sensory. And then there's a deep branch, which is kind of disappearing from view here. But the deep branch would be the one that goes down into the deep palm, and we'll see it again in a second when we switch to the next slide. But if we look just at the superficial branch of the ulnar nerve, It's giving off one branch that supplies the medial surface of the fifth finger, the medial surface of the pinky. And then down here, this remaining piece of the ulnar nerve splits to supply the lateral side of the pinky, as well as the medial side of the fourth digit. So the superficial ulnar nerve is responsible for sensory innervation to the entire fifth digit or pinky and half of the fourth digit or ring finger. That would be the medial half. The median nerve is the nerve that actually goes through the carpal tunnel. Remember what I said earlier, though, there's this little superficial branch that supplies the skin of the palm. That actually comes off of the median nerve before the nerve goes through the carpal tunnel. So that little palmar branch is usually not impacted by carpal tunnel syndrome. It's only this part of the median nerve that actually goes through the carpal tunnel that may be impacted. This portion of the ulnar nerve, or excuse me, this portion of the median nerve is going to give off something called the recurrent branch that I mentioned earlier. This is the motor nerve that supplies the three thenar muscles here at the base of the thumb. So that's why in cases of carpal tunnel syndrome, you lose that nerve because it's compressed, and so you lose innervation to the three thenar muscles. The median nerve also gives off sensory branches. There are sensory branches out to the thumb that supply much of the skin of the thumb. There are branches to both sides of the index finger, branches to both sides of the middle finger, and also a branch to the lateral side of the fourth finger. So median nerve is responsible for sensation to most of digit 1, the thumb, all of digit 2, all of digit 3, and half of digit 4. So it's interesting how the fourth digit or ring finger has kind of a shared innervation where one side of it's supplied by ulnar nerve and the other side supplied by median nerve. And here on this deeper view, once again, you see ulnar nerve splitting into superficial and deep branches. Here's the superficial branch, which is sensory to digits 4 and 5. And then the deep branch ends up crossing very deeply across the palm, comes all the way over to the lateral side of the palm. This is where it's innervating that adductor pollicis muscle, and it's also innervating all of those interosseous muscles that lie in the spaces between the metacarpals. So this is another structure that you should look for in the deep palm dissection. In fact, usually you can see that deep palmar arch artery and the deep branch of the ulnar nerve lying side by side in the deep palm dissection. I helped a few people dig that out to make sure they found it. And then here you see median nerve coming through the carpal tunnel, giving off sensory branches to digits 1, 2, 3, and half of 4. And then you also see that small recurrent branch that would supply the three thenar muscles of the thumb.